My name, my name is Kelly Coble. I'm the program director for MAX, the Maryland Addiction Consultation Service, and our sister program, MAX for Moms. Welcoming our guest speaker today, Dr. Barisco Tyler. I hope that's the correct pronunciation of your last name, Dr. Barisco. We're really excited to have you joining us. I will just give a brief overview of the MAX program, and then I'm going to pass it to my colleague, Dr. Bethany DePaula, to introduce Dr. Briscoe, and then we will hand it over for the rest of the hour. But as many of you know, MAX is a substance use access program. We serve the state of Maryland and provide consultation, training, and technical assistance to prescribers, healthcare providers, pharmacists, and their teams across Maryland. We have a warm line where providers and their teams can call in to ask any question about patients who use drugs, have substance use disorders, or pain management needs, and speak to one of our addiction medicine physicians or pharmacists for consultation. We also provide training like what we're doing today and technical assistance. So we're really happy to answer or talk with you about any question you might have and are excited to welcome our guest speaker today. And I will let Dr. DePaula give a full and warm welcome. So thank you again for being with us, Dr. Briscoe. Dr. DePaula? You're muted, Dr. DePaula. Oh, Marciel, do you need to unmute her? Oh, there you go. Oh, Bethany, we still can't hear you. I wonder if it's your headset. Because it looks like you're unmuted. We cannot hear you now.
Let me try switching.
Yep, there we go.
Oh, there you go. There you go.
Oh, hold on. Can you hear me now?
Yes.
Okay. Wow. Well, the best thing about, or maybe the worst thing about virtual presentations is all the tech issues. So I apologize. I had a ton of them this morning, but I am very excited to introduce Dr. Morosco today. He is an assistant professor in Health Outcomes Division at the University of Texas, Austin College of Pharmacy. And he serves as the director of Pharmacy Addictions Research and Medicine Program. He earned his PharmD, his Doctor of Pharmacy degree from the University of Texas at Austin, and his PhD in Pharmaceutical Health Outcomes and Policy from the University of Houston. He's a registered pharmacist, which is great, and his research focus is really on evaluating and improving the quality of care for persons with opioid use disorder, which is why we're so excited to have him for Pharmacy Week and here to present today. And one of the big initiatives and one of the reasons that I know him personally is his effort to lead a collaborative project between the National Associations of Boards of Pharmacy, the National Community Pharmacists Association, and three colleges to create a document which is affectionately known as the Pharm OUD guideline, and that stands for the Pharmacy Access to Resources and Medication for Opioid Use Disorder Practice Guideline. And this is a wonderful consensus, evidence-based guidance to address clinical obstacles that limit access to medication for OUD in the community pharmacy setting, specifically buprenorphine. And Max is just so excited to have him present today. He's going to be presenting Closing the Loop, Transitions of Care for Persons with Opioid Use Disorder. And I'm hoping you don't have the same tech issues I do. I'm handing the baton off to you. Thank you so much for presenting today.
Thank you very much, Bethany. I appreciate that introduction. That was fantastic. Let me get my slides pulled back up here. So, as Dr. Paul said, I am a pharmacist by training and currently a professor at the University of Texas at Austin. Much of the work that I'm going to discuss today, I performed at the University of Houston over the last couple of years, and I'm excited to speak to you all in Maryland, where I'm sure the weather is much better than it is here in Texas. It's still about 85, 88 degrees, so not quite fall yet. So our objectives for today, we're going to talk a little bit about the risks of untreated opioid use disorder and the effects of disrupting treatment for patients with OUD who are otherwise stable in treatment. We'll also talk about several barriers to buprenorphine access in the community pharmacy setting and provide some solutions to get around those barriers. And finally, we'll talk about how we can initiate and continue pharmacotherapy for opioid use disorder in other settings of care, including in the inpatient and community-based setting. So, a little disclosure before we begin. I am currently funded by the Texas Targeted Opioid Response. That is a state opioid response grant through Texas Health and Human Services from SAMHSA. Nothing I discuss today represents the views of of Texas Health and Human Services or the Substance Abuse and Mental Health Services Administration. Finally, there are a few points in the slides today that also address on legal and regulatory matters. It's important to remember that I am not an attorney, nor do I play one in TV or in any other area of my life, because that would be miserable. And so nothing I say today should be interpreted as or misinterpreted as legal advice. So to begin, let's talk a little bit about opioid use disorder and really how we got here. I think many of us are very familiar with the fact that opioid use oftentimes starts with pain, or with poorly managed or overtreated pain. And pain is very common in the United States. In fact, about 20.9% of US adults are living with a condition likely to cause chronic pain. And about 6.9% of US adults are living with high impact chronic pain, or pain that interferes with our ability to perform activities of daily living or instrumental activities of daily living. Pain is an incredibly costly condition in the United States, or costly symptom in the United States, and pain leads to about $560 billion a year in lost productivity. America is unique in that we struggle with multiple comorbid conditions that sort of come together and converge to cause pain or to cause highly prevalent pain. We know that pain and it goes hand in hand with multimorbidity. So if you are living with 6 or more chronic conditions, you are 1.4 to 3 times more likely to experience chronic pain. Chronic pain is also very common in mental health conditions or in people who are experiencing depression, anxiety, and other psychiatric conditions. In fact, about 30 to 56% of people living with mental illness are also living with comorbid chronic pain. And finally, it's no secret that we have a bit of an obesity problem in the United States, although Ozempic is quickly getting us out of that trench. But people who are living with obesity or who are overweight are anywhere between 1.5 to 2.2 times more likely to experience chronic pain. And we take our pain very seriously in the United States. In fact, I'm sure many of us were working in a period of time where pain was considered the fifth vital sign. The Joint Commission was sort of coached by the pharmaceutical industry and by patient advocacy groups to really take pain seriously. And the quality of care in hospitals was really evaluated based on how well pain was managed. Pain management remains a key component of patient satisfaction in inpatient settings. The nefarious side of this is not our desire to make people comfortable. That's a noble cause. The nefarious component of this is that many of us were misled, particularly our prescribers, pharmacists, and other clinicians. There was a single letter to the editor published by Porter and Jick in the New England Journal of Medicine in 1980 that claimed, and that this is the entire publication, that claimed that opioid dependence was relatively uncommon in patients who have legitimate pain. And this letter led to a national marketing campaign from Purdue Pharmaceuticals and by several other companies by the time we were in the 1990s, essentially claiming that opioid medications, highly potent prescription opioids, were very safe in people who were living with pain, and that routine daily use in non-cancer pain was highly unlikely to lead to addiction. And there was a lot of lifestyle messaging around these products as well. This is probably one of my favorite pharmaceutical advertisements of all time, and I consider myself to be a mild connoisseur of pharmaceutical advertising. And if any of you have an OxyContin fishing hat and want to sell it to me, please let me know. They did market them for a while or provide them to physicians for a while. But the messaging was that these medications can give you your life back. But as we quickly found out and continue to struggle with in our nation, we know that that was not necessarily the truth. The one thing that sort of steers my research is this graph right here. And I would imagine that many of us are familiar with the CDC's provisional opioid overdose counts. And we can talk all day about how accurate or inaccurate these counts are, but they're what we have, right? And I think it's really important to evaluate the effectiveness of interventions for opioid use disorder by their effect on national opioid-related mortality. And so we can do that when we look at sort of the regulatory history of prescription opioids. In about June of 2015, due to increases in prescription opioid related mortality, the move was to sort of reschedule hydrocodone combination products. This was about the time that I was in pharmacy school, and all of a sudden, hydrocodone combination products went from DEA Schedule 3 to DEA Schedule 2. And this was sort of the first major shot across the bow to regulate the prescription opioid supply. And we all know how effective prohibition is. And in fact, over the next several months, opioid-related mortality continued to increase. And one thing that I think is really important to remember is that as prescription opioids became harder to get, we really didn't see changes in mortality. And noticing that, the CDC then released a practice guideline in 2016 that made several recommendations that were intended to curtail opioid prescribing in the United States. These recommendations were described as risk mitigation strategies. And the expert panel that designed the CDC practice guideline acknowledged that many of these risk mitigation strategies that were recommended really carried no level of evidence. For instance, one of the risk mitigation strategies recommended in the 2016 guideline was for clinicians to use urine drug screening before starting opioid therapy. They then admit that they found no evidence that that would actually be effective in reducing opioid prescribing for pain or in preventing risk of opioid use disorder. The 2016 guideline also limited the duration of opioid treatment, stating that 3 days or less will often be sufficient and more than 7 days will rarely be needed for acute pain. Again, this recommendation was not made with evidence. It was made with the general consensus of the expert panel. Then several of the recommendations contained in the 2016 guideline were quite ambiguous. Clinicians should evaluate the benefits and harms of continued therapy every 3 months or more frequently. Who knows? It's really difficult to make decisions when the evidence is not necessarily there and when the recommendations are sort of written in this ambiguous and oftentimes indirect way. Did the 2016 guideline work? Well, yes. It worked for one purpose. We saw the rate of opioid prescribing fall by almost 50% between 2016 and 2022. But did it lead to changes in mortality? Well, we all know that it did not. By 2022, we were almost experiencing 100,000 opioid-related deaths per year. And I think it's important here to notice a couple of things. First of all, we saw a pretty steep decline in the rate of heroin-related mortality. And I think many of us know why that is. It's because we saw some changes in the US drug supply. And then as prescription opioids became more and more difficult to obtain, we started to see more people turn to illicit sources to manage their pain. And we started to see this dramatic increase in synthetic opioid-related mortality due to the penetrance of fentanyl into the US drug supply. And by the time that 2022 came around and mortality really had not improved, the CDC saw it fit to think about actually restructuring their recommendations for opioid prescribing. And one of the reasons they did so is that because by this point in time, many states had taken the recommendations in the 2016 guideline and actually began to codify them into law and regulatory policy. Over 30 states by 2022 had at least one law that limited the prescriber's authority to prescribe opioid medication. A lot of these laws related to the duration of acute opioid prescriptions or the need for continued patient monitoring. But almost more importantly, we also began to see payers push back, and payers began to limit how many days' supply of an opioid medication they would pay for. Now, if you were a patient in this time period who had major orthopedic surgery and potentially had some complications and needed a slightly longer duration of post-surgical opioids to manage your pain, the process to actually have that longer duration opioid prescription approved was fraught by not only legal and regulatory issues, but also by payer limitations as well. Essentially, it almost became impossible for providers to do what they thought was best to manage pain in many states and for patients who were insured by many private and public payers alike. The broader impact of this period of prohibition, however, was to really change the way that prescribers and pharmacists thought about opioid prescribing, about the management of pain, and ultimately about the management of addiction. I think about this like a scale, and this really is, I think, a very useful analogy here, where we sort of have the clinical need of the patient. We have a patient with legitimate pain that has a legitimate etiology, a legitimate purpose, and we need to manage that pain. Or we have a patient with opioid use disorder who would benefit from buprenorphine or methadone or some other form of opioid agonist therapy that is also highly regulated, right? But then there's this administrative risk. Well, if I dispense that, if I prescribe that, the DEA is going to investigate me. If I dispense that, I prescribe that, I'm going to run into issues with the pharmacies in my community, right? They're not going to want to fill my prescriptions anymore. So prescribers and pharmacists alike are constantly weighing the needs of their patients with the risks of providing care to them. And I'm not saying that we can eliminate administrative risk and liability altogether, but we have to think about this tipping point when we make new policy and when we make new recommendations. It's important to think about this as sort of a pervasive process. So providers and pharmacists, they don't only exist in the limited sphere of their practice, right? They exist within interpersonal communities, sort of the microscopic level of interaction, a provider or a pharmacist interacting with a patient. And then they exist within a broader system that might be a pharmacy chain or a healthcare system. And then that system exists within a grander state, federal, and administrative ecosystem, a policy environment, the micro, meso, and macro levels. And we see impacts of this imbalance between clinical necessity and risk at all points. So, at the point of the person, a pharmacist or a physician interacting with a patient, what we oftentimes see is we see stigma, right? We see that provider who is all of a sudden suspicious of this patient. Well, what is informing that stigma? Obviously, their own personal judgments, their own personal attitudes toward people who use drugs or who are perceived to be at risk of addiction or living with substance use disorder, right? There's some interpersonal characteristics there, but there's also that broader environment. If you're a physician, and your employer, the system you work for, requires you to take risk management CE every year that is very draconian and encourages you to really highly limit your opioid prescribing. Or if you have a very robust opioid stewardship program that may not be the most patient-centered, you're encouraged to be suspicious of these patients, to judge them all suspiciously. The same in a pharmacy, right? If you're constantly worrying about the inventory of controlled substances, or you're worried about that regulatory climate, that leads down and that implicates your individual patient decision making. And what inspires that sort of meso level, the attitude of the system? Well, that's the attitude of the state, the attitude of the federal government. And as we'll see, those attitudes are not entirely unwarranted. We've seen a massive amount of money change hands due to opioid-related harm. States are very much interested into curtailing prescribing and to extracting financial penalties from the organizations that are perceived to have caused much of this harm and did cause much of this harm. But what this has led to is this phenomenon of policing patients. We are encouraged to be the police. We don't go to school to be the police. I would be an awful, awful police officer. I'm not a very good pharmacist because, I'm a professor and those who can't do teach, right? But still, I would be a far worse police officer. And and if you haven't read it, this is a fantastic book by Liz Chiarello called Policing Patients about sort of how this phenomenon has unfolded over the last 20 years. And I'd really recommend this book if you're interested in kind of how this has worked. We do have a solution, though. Our solution is not necessarily policing our way out of this crisis. The war on drugs has failed. I'm sure many of us realize that and recognize that. And unfortunately, we're not really winning that battle as we try to fight it again right now in this country. The solution is getting people the health and psychosocial supportive services that they need to achieve a meaningful and sustainable recovery or to live safely in active use. You can't treat somebody if they're not here, right? Um, I view a major part of that solution as opioid agonist therapy, and I'm a huge proponent of buprenorphine because it is the only form of opioid agonist therapy that is currently available or could be available in every community pharmacy. It's much more accessible than methadone, and methadone is a great drug. I have nothing against methadone, but for a lot of the patients who are living way too far away from an OTP, buprenorphine is their only option. The problem is that a lot of pharmacies just don't dispense buprenorphine. This is from a series of studies, two of which were conducted in the research center that I now lead, but before I got there, by a guy named Lucas Hill, who's now at the University of Pittsburgh, great pharmacist. If you ever get to meet him, great researcher. And they found that only about 40% of pharmacies in the state of Texas were willing and able to dispense a 1 week supply of buprenorphine. And then when they extended their sample nationally, they found that somewhere around 51% were willing and able to dispense a 1 week supply of buprenorphine. What was more staggering in their second study conducted in 2022 was that they found that about 64% of pharmacies that did not have buprenorphine in stock just wouldn't even order it. They weren't even open to the idea of dispensing it. This has now been revalidated in a number of these audit studies where essentially people call a pharmacy over and over again and see if that pharmacy has buprenorphine in stock. One of the most interesting ones that I've seen was actually conducted by Bicycle Health, Weiner et al., which was conducted in 2023. And what they found was that when they were calling as clinicians to ask if that pharmacy could fill their patient's prescription, um, only about 57.9% of pharmacies actually had buprenorphine in stock. One of the more and we'll get to this in a little bit, but one of the more interesting things about their study was they found a significant amount of variability across states and pharmacy chains. Why is this? Why are not all pharmacies stocking buprenorphine? Well, like I mentioned earlier, there's a lot of misconception around the level of oversight required. This was from a study that I conducted several years ago now in the Texas Prescription Drug Monitoring Program, where we essentially built this gigantic statistical model to determine what predicted whether or not a prescriber or a pharmacist actually queried the PDMP, actually looked up a patient before prescribing or dispensing a medication. And what we found was that, and there are a lot more effects in this model. If you're interested, the citation of the paper is there. But what we found was that pharmacists were about 1.4 times more likely to query a prescription for buprenorphine than they were a prescription for for codeine, excuse me, and about twice as likely to query a prescription for fentanyl as they were for codeine. And the reason I've kind of boxed both of those is I think they both say a lot. Fentanyl is a highly, highly potent opioid. Yet pharmacists just aren't really, they're barely more interested in looking up in the PDMP than they are buprenorphine. So they are just as suspicious of a very full agonist as they are of a partial agonist like buprenorphine. Prescribers were actually more likely to query a patient prescribed buprenorphine than they were a patient prescribed any other opioid agonist medication. Prescribers in this sample appeared to be more suspicious of buprenorphine than other agents. So as I mentioned earlier, there's a lot of variability in buprenorphine availability across pharmacies, and this varies not only by state, but also by pharmacy chain. I don't think you have Publix in Maryland, but only about 31% of Publix pharmacies actually had buprenorphine in stock in the Bicycle Health sample, compared to about 70% of Walgreens. Um, but what I'm very, very proud of is that HEB, a Texas grocery chain, was actually more likely to consistently stock buprenorphine than any other pharmacy. And that's quite shocking because I never get to call Texas a public health leader unless I'm presenting a slide, which is awesome. So why is HEB more likely to stock buprenorphine? Well, HEB has borne significantly less liability than other pharmacy chains, and certainly less so than the drug distributors in multi-state opioid litigation. In case you are unaware of what is going on in the greater world right now, there have been about $51 billion in legal settlements between states and opioid distributors, opioid manufacturers, pharmacy chains, and other entities related to their role in provoking or accelerating the U.S. opioid overdose crisis. One of the things that came out of this settlement was this idea. Or one of the things that came out of this settlement was an agreement between pharmaceutical distributors and state attorneys generals. And this agreement essentially discharged some financial liability from the distributors in order to, in exchange for a series of terms by which the distributors would sort of monitor the dispensing behavior and purchasing behavior of their pharmacy clients. So when I say distributor, I mean the groups that are purchasing or that are shipping medication to pharmacies. Prescription drug wholesalers. And when I say clients, I'm talking about the pharmacies that are ordering those medications. And this is a very long agreement, and there are a lot of components of these suspicious order reporting systems. But one of the components in here is that distributors should pay extra attention to pharmacies that order unusual formulations. One of those formulations named in the agreement are buprenorphine products formulated without naloxone, what I will now call buprenorphine mono product. The interesting thing about the agreement is that it gives distributors a lot of leeway in how they make their own rules. They can essentially design programs however they'd like, as long as they are doing their due diligence and monitoring suspicious orders from their pharmacy customers. One of the things in the agreement, provisions in the agreement, allows distributors to regulate products by drug family. Drug family is not very well defined, and while I have not had confirmation of this from distributors themselves, many of the pharmacists that I've spoken to and worked with over the last couple of years that have issues purchasing enough buprenorphine to dispense to their patients report that if they cross their buprenorphine threshold for mono product, they now can't order other buprenorphine products. So it would appear, and it has been reported consistently by pharmacists in multiple practice environments, that distributors are sort of holding all buprenorphine products to this threshold. So what I'm getting at is that pharmacies are not necessarily just not dispensing due to stigma or due to concern or misconceptions. Many pharmacies want to dispense buprenorphine, but cannot do so because their distributor will not adjust their thresholds to be able to take care of the needs of their patients. Why is HEB doing okay? Well, HEB is a pharmacy chain, and many of these pharmacy chains also have their own limits or their own tools in place to limit the number of opioid prescriptions that their constituent stores or pharmacies dispense. This is particularly common for the larger pharmacy chains, like the ones named on this slide, that were named the National Opioid Settlement. It's important to note that HEB was not named in the National Opioid Settlement. State attorneys generals brought suits against pharmacies in their own states or that were operating in their states. HEB only operates in the state of Texas, and while they are a very large grocery chain and a very large pharmacy system, if you sued HEB as the Texas Attorney General, you may not get reelected to office. We really like our HEB. And I do think that because HEB did not bear opioid liability in the National Opioid Settlement, that they have been less preventative or less proactive at reducing opioid dispensing. These settlements had a massive impact on the way that pharmacy systems provide care to patients with substance use disorder. But even outside of chain pharmacy settings, we see impact. This is a quote from a series of focus groups that we did with pharmacists in Texas, California, and West Virginia. And there was a pharmacist in a small county in East Texas, Nacogdoches County. If you've heard of Nacogdoches before this presentation and you live in Maryland, I'll send you $1 in the mail. I would be amazed if somebody's ever been to or heard of Nacogdoches, Texas. But Nacogdoches, little town in East Texas, very rural area. Only about 64,000 people in the county, 32,000 of them reside in the town of Nacogdoches. It's a very impoverished area. About 23.3% of families live below the federal poverty line. And there's only 9 pharmacies in this very large county. It's a 35 square mile county, and there's only 2 independent pharmacies. And one of those independent pharmacies also services hospice agencies in the county and in the surrounding rural areas. And she mentioned in this focus group that she was dispensing buprenorphine, but running into wholesale issues. And if she crossed her buprenorphine threshold, she couldn't dispense other opioids, which meant that she couldn't provide care to her hospice patients. So she was at a nexus where she literally had to choose between caring for patients with addiction or caring for patients at end of life, and she chose the hospice contracts. I don't blame her. Hospice contracts keep a lot of small independent pharmacies financially afloat. But what that does is it takes a pharmacy sort of out of the dispensing pool for the county and leads to the loss of a point of access for people that have substance related needs. Um, and I'm not saying that these administrative issues are the only concern here. There's also a significant amount of stigma that patients experience at the pharmacy counter. Is a quote from another focus group in Texas, where a pharmacist essentially came up with a very vibrant scenario as to why he would not provide care to patients with opioid use disorder. Our discussion was focused on buprenorphine dispensing. We were not talking about infection control. We were not talking about needle exchange. We were literally talking about buprenorphine. And this pharmacist goes off on this massive tangent about how if you start dispensing buprenorphine, then they're going to show up for the needles and they're going to want to exchange needles. And then you've got a 17-year-old girl working the drive-through at the pharmacy. And how are people going to feel if they see a 17-year-old cashier exchanging needles at the pharmacy window? I don't know, because this isn't what we're talking about. It's not germane to our discussion. A lot of issues in the pharmacy environment, and surely the federal practice guidelines cover this, right? They do not, or they did not, and I think they will now that they are being updated. But previously, um, the SAMHSA Tip 63, Treatment Improvement Protocol 63, the SAMHSA's guideline on medications for opioid use disorder, claimed that any pharmacy can fill a prescription for sublingual or buccal buprenorphine formulations. Any pharmacy. As we've just substantiated, about half of pharmacies just do not. And so really there was no guidance as to how to circumvent these barriers in the pharmacy setting. And now I think is the time to address that because we've had sort of decades of letting one party at a time control the conversation. We let pharmaceutical manufacturers dictate how pain was managed and how patients were needs were met for decades. And then after that, we sort of turned things over to enforcement and legal entities and regulators. Neither one of those groups worked well together, and there was very little room for patient and provider input. And a lot of what happened, a lot of our policy in the controlled substance space in the last I don't know, 30, 40 years at this point, relied on untested assumptions. This idea that if we make the substance harder to get, people will not use it. But we're not addressing behavior. We're not addressing environment. We're not addressing access to employment, access to housing, access to care. We're not thinking about things. We are only thinking about a restrictive or prohibitionist lens. And because that assumption prevailed, we have to think about what happens when that assumption is applied. Newton's third law, for those of you that don't remember high school physics, as I certainly do not, Newton's third law states that every action has an equal and opposite reaction. And when we make substances more difficult to get, and when we put limits or regulatory constraints on access to treatment, the reaction will always be the opposite, right? It's always going to lead to detriment to patients. And we have to keep patients first in our policymaking and in the way that we regulate, because prohibition has historically not been an effective way to prevent or treat substance use disorder. Which leads us to sort of the work that I do. So we set out with this idea that it was about time to really think about how we engage the pharmacy workforce to make buprenorphine products more accessible. So to understand why pharmacists weren't dispensing buprenorphine, we used a stakeholder engaged approach where we went into the community and we really wanted to speak to pharmacists and understand what was going on with them. From there, we brought in people from all across the continuum of care, patients, prescribers, pharmacists, people that worked for distributors, people that worked for DEA, and we had them address the concerns of pharmacists and come up with recommendations together that would work for all parties. And we wanted to bring in evidence to really create a practice guideline that would address some of the not only clinical aspects of providing care to patients with opioid use disorder, but also some of the regulatory and administrative aspects as well. So we conducted a series of focus groups, as I mentioned earlier, with pharmacists in Texas, California, and West Virginia. These were average bench pharmacists recruited from Walgreens, CVS, independent pharmacies. And we asked them a series of questions about why they had difficulty dispensing buprenorphine. We found several key areas come up, and here are some example quotes from that focus group. Stigma was prevalently mentioned. We talked about that a minute ago. That's the same quote. But also, we had a lot of pharmacists express concerns about enforcement, mentioning that they had a visit or an inspection from the DEA and they wanted to see the buprenorphine records. And then this idea of wholesale restrictions came up repeatedly. Once we hit our quota, it's game over. We ended up defining a series of areas that we knew we needed to provide guidance or recommendation in. We needed to talk about payment. How do we make this financially sustainable for pharmacies? We needed to talk about continuity of pharmacotherapy. We needed to remind pharmacists that there was no maximum duration of treatment, that the evidence doesn't support a maximum duration of treatment. We talked about red flags, prescription drug monitoring programs, how to appropriately and responsibly evaluate a prescription for a patient who lives in a rural area and is traveling 50 miles because there's no pharmacy that dispenses buprenorphine around them. We talked about wholesale, how to communicate with your distributor, how to purchase buprenorphine. And we talked about how to work closely both as an employer and with your employer to ensure that you are able to meet your patient's needs. So this is an overview of the study design. In the interest of time, I'm not going to spend a ton of time on this, but we used what's called a Delphi approach, where what we did was we essentially formed these vignettes, these descriptions of problem areas from our focus groups with pharmacists. We then put them in front of a expert panel and had them form open-ended recommendations. So they would write a statement as to how they would address the problem that was being described. We then took those recommendations and we combined similar recommendations into statements and had the panel vote on them through a couple of rounds until about 70% of panelists, or more than 70% of the panelists, agreed that the recommendation was appropriate. Between rounds, we would revise those statements based on feedback from the panel. In our fourth round, we voted on any remaining recommendations after a period of open discussion, of live discussion. The panel was blinded to who else was on the panel the entire time. The next thing we did was we held a public comment period where the National Association of Boards of Pharmacy posted our practice guideline on their website and solicited public comments. We ended up receiving public comments from a wide variety of organizations, including the American Society of Addiction Medicine, the American Medical Association, the American Pharmacists Association, American Society of Health Systems Pharmacists, and many, many individuals. And then we incorporated that feedback, and this is where Dr. DePaula came in. We then had a review meeting at National Association of Boards of Pharmacy headquarters in Mount Prospect, Illinois, where a secondary panel of experts reviewed feedback from the public and helped us incorporate those revisions into the guidance document. The final document is available at that QR code. You're more than welcome to download it, or if you Google PharmOUD guideline, you'll find it posted on multiple websites. The recommendations in the document are very straightforward. They're not overly progressive or too risky, in our opinion. We encourage pharmacists to stock buprenorphine. We think it's important to recognize that opioid use disorder is a chronic disease that needs to be treated. We talk about using PDMPs responsibly. We talk about telehealth and how to treat people with compassion. And our recommendations, I think, were so common sense in many ways that they were not difficult to get endorsed by a wide variety of organizations. So outside of the sponsor organizations, NABP and the National Community Pharmacists Association, the guidance was also endorsed by ASAM, the American Pharmacists Association, ASHP, Vital Strategies, which is a patient advocacy organization, the American Association of Psychiatric Pharmacists, and the National Pharmaceutical Association. Thinking through some of these issues, though, we thought we needed to go further. And one of the other big areas that came up repeatedly were these issues that pharmacists had with their distributors. Looking through some of the focus group feedback, we found that pharmacists think about their distributor thresholds and their distributor interactions every time they dispense a buprenorphine prescription. We identified sort of 5 key themes here. Pharmacists are very aware of their threshold. It's all they think about when they're dispensing an opioid or a buprenorphine prescription that is otherwise clinically legitimate. They feel the need to ration their buprenorphine to save supply to the end of the month, to turn down new patients. And they're concerned about care interruptions. Happens all the time where if they accidentally dispense to too many people early in the month, they can't order anymore. And then all of a sudden they're cutting a patient off and having to find somewhere to go. They talk about payment a lot. It's difficult for them in many states due to payer policy to actually make money from dispensing buprenorphines. They don't want to do it. And then many are afraid of the DEA. We recently published another paper in Drug and Alcohol Dependence Reports that provides several recommendations to distributors and to pharmacists and to the Drug Enforcement Administration to hopefully reconcile some of these barriers. And we're currently working with the National Association of Boards of Pharmacy to bring these parties together to try to find some form of resolution. And I hope that we see a product come out of that soon. But there is interest in addressing some of these wholesale issues. Moving past the pharmacy setting, opioid use disorder is a prevalent problem across all settings of care. In fact, about 1 in 8 healthcare dollars is spent on addiction in the United States of America. And this is not just due to pharmacy issues, obviously. It's due to difficulties in other settings of care as well. But what we do know is that if we cannot initiate or maintain care for patients with substance use disorder, which is very difficult to do, that patients will be at a greater risk of morbidity and mortality. So there's some key questions here that have to be answered. How do we make care collaboratively or collaborative? How do we enhance the value of providing care to people with opioid use disorder? And what strategies can we use to improve the transitions of care? So I thought we'd take a minute here if you want to put some comments in the chat. If you could kind of maybe provide some feedback on kind of what the barriers are in your health system to managing these transitions of care between the inpatient setting, the outpatient setting, and the pharmacy setting. I'd like to know kind of what key players you think about and how you engage other clinicians, other stakeholders, patient advocacy organizations, recovery support groups. How do you identify partners? And finally, what do you do if you're in the inpatient setting or in the community setting to ensure that your system is promoting continuity of care for opioid use disorder? So go ahead and put that in the chat. I'm going to keep moving as answers roll in. And then I think we should have some time at the end to maybe discuss some of that in the question and answer session. Okay. So recognizing that this is challenging, that it's challenging to take a patient from the community setting with relatively little known medical history and either identify that they were in treatment or need treatment, it's difficult to make sure that we are continuing care when we get somebody from the community into the inpatient system. Oftentimes, on the other end of that spectrum, if a patient is admitted for an opioid overdose or comes into the ER post-overdose or in withdrawal, a lot of systems are just not equipped to initiate and manage opioid agonist therapy. A lot of this is due to stigma. Hospital systems don't want to deal with it. These are viewed as problematic patients a lot of the time, as gomers, as people that cause issues. And that's really not a great attitude, but we have to address it in our work. Hospitals are also concerned with liability, regulation. A lot of hospitals just are not equipped to provide services directly in their emergency departments when we have sort of loosey-goosey regulations around opioid agonist prescribing in those settings. And finally, there just aren't a lot of clinical champions. How many of you work in a health system where the dean of the medical faculty or a physician or a department head is championing treatment for opioid use disorder? How many of you work in a pharmacy setting where your pharmacy director is championing treatment of opioid use disorder to the administrative staff? And a lot of hospitals want to do something, they just don't know where to start. So I worked with the American Hospital Association, the Centers for Disease Control, on a CDC-funded project with a number of other partners, including health systems partners, to really think through ways that health systems could better address opioid use disorder and also manage treatment around critical transitions of care. I was a subject matter expert on this project, and so my role was to work with physicians and administrators to essentially meet with small teams from three health systems to think through and then ultimately implement and continue to evaluate and improve an opioid use disorder treatment strategy for their health system. At the end of the day, we worked on disseminating a implementation toolkit that is publicly available now to help guide some of these transitions of care. We worked with three health systems, Oregon Health Science University, OHSU, which has an established great SUD program, but they were really working on addressing some of the remnants of stigma in their system and bringing clinical champions and administrative champions on board. We worked with the University of Kentucky, who had somewhat of an SUD service line, mainly out of necessity, but really wasn't in a position to improve, to bring people all the way from the emergency department where they come in back to the community and keep them on medication for opioid use disorder. And then the last partner was Trinity Health in Connecticut. And Trinity really wasn't doing much. They were very, very interested and passionate about treating substance use disorder. They wanted to work closely with community-based groups and bring in peers to be able to really implement an effective and person-centered service line. They didn't know how to do it. And so they were at the table along with these other two systems to really think about how to drive care. So you can download the toolkit at this QR code here. You can also Google Bridge to Care, an American Hospital Association. I feel like every document in the opioid use disorder space has the word bridge in it. I don't know where we thought we became civil engineers, but we're big fans of bridging. Anyway, you can get Google Bridge to Care, American Hospital Association, and you can download the toolkit. Um, I thought this process was great. And as an academic who makes really boring academic products a lot of the time, posters, manuscripts, boring stuff that nobody reads a 50-page practice guideline, et cetera, it was great to see what some of these systems came up with to really implement locally and acutely to improve the quality of care where they work. So this was something that the University of Kentucky created. That really just kind of talks about medications for opioid use disorder. And usually when you see OUD content, it's kind of awful. You know, it's oftentimes just dark and somber, and this is colorful. It makes opioid use disorder look like an approachable condition that can be treated. And what they did with this sign is they actually just hung it up on all of the bathroom stalls in their hospital, on the back of the stall, just on the door. So if you're sitting there on the toilet, you're looking at this sign and you're like, it makes you think about maybe addressing opioid use disorder. You can't not look at something like this. And so I think just like a tool like this that is easily implemented is great. And it was great to see these health systems really think through what would work for them and what could transfer to other systems as well. In the toolkit itself, we work through sort of a multi-step process where we talk about how to plan for or who needs to be at the table to work on discharge planning. And we talked about the need throughout the document to really focus on discharge from the time of admission. We identified that as a really critical component of treating people with substance use disorder in the inpatient setting and ensuring that they have continuity of care in the community. For pharmacists, we talked a lot about how to build relationships between inpatient pharmacists and their community counterparts. There's a tremendous amount of evidence, as Dr. DePaula can attest, because she's contributed to this body of evidence, but there's a tremendous body of evidence that suggests that sort of forming relationships between hospital and community-based pharmacists can go a really long way in improving treatment adherence and continuity of care for patients with substance use disorder. We also talk about the lapses in communication between the inpatient setting and the community setting. As a former community pharmacist, I find it's very relatable that a lot of the time you get a prescription in your pharmacy and it's from a ER physician and you can't fill it because they left the day's supply, the quantity off or whatever. And you try to call the ER and you get an answering service and that clinician is gone and nobody can look it up in the EMR. Right. So we really talk about how we can leverage pharmacists in particular to ensure that those prescriptions are complete and to ensure that orders are appropriate to be filled in the community setting. And then finally, we talk throughout the document about how to bring in and how to engage leadership through the use of strong clinical champions, including pharmacy champions, throughout the health system. And one of the things we really focus on in there is leveraging the Pharmacy and Therapeutics Committee, the P&T Committee, to ensure that this group that's kind of tasked with making safety and value-based decisions is able to see the relative value of managing opioid use disorder. There's some great case studies throughout the document, including a lot of information on the use of the 72-hour rule. And if you are a pharmacist and you're interested about dispensing um, methadone in your hospital using the 72-hour rule, I would highly recommend that you read this great paper by Emily Skogran and Honora Englander. It's just a tremendous paper. And for those of you who are not familiar with the 72-hour rule, practitioners, any practitioner is allowed to dispense, not prescribe, but dispense a 3-day supply of narcotic drugs, pretty much methadone, to one person or for one person's use at one time for the purpose of initiating maintenance treatment or detoxification treatment. What does this mean? If it's a Sunday and somebody comes into your ER and they say they're on methadone and you can't get a hold of their OTP or you need to send them home, you can give them a 72-hour emergency supply. Some hospitals are sort of using this as a very flexible bridge clinic, and they're dispensing methadone quite routinely out of their emergency departments. And so, think about ways that you can implement this tool to ensure and promote continuity of care for your patients with substance use disorder. The rule itself is confusing. I would highly recommend that you read Emily and Honora's paper if you are interested, and I'm happy to connect you with them if you have questions. In addition to that, though, we talk a lot throughout the document about actual actionable steps to begin dispensing methadone in the inpatient setting. And we talk about really how to get those patients into an OTP quickly and efficiently post-discharge. We give several examples of how to take care of patients' social needs. So this was from a program at OHSU where they struggle with patients who don't have ID a lot of the time. And for those of us that provide care to individuals experiencing homelessness, we see this all the time where there's no identifying documents. So they are maintaining their own sort of identifying database to ensure that they can quickly resume care to patients that are readmitted into their health system. And finally, there's a series of tools in here for pharmacists to help pharmacists engage as clinical champions with leadership and with clinicians to really steer some of the decisions around opioid use disorder care in the inpatient setting and the ER setting. So you feel free to take a look at the document itself. These decision guides and discussion guides are all in there. It's meant to be a working document for a health system. And one of the things that I was really proud to put in this document was this line right here. It's important to treat every prescription as a transition of care. We should be using hospital-based pharmacists to educate patients and their community pharmacy counterparts about the importance of successful treatment continuation. So a few assessment questions. I'm just going to go through these real quick. So the 72-hour rule allows providers to blank a 3-day supply of methadone for the emergency treatment of opioid withdrawal. Bit of a trick question. The word is dispense. We are not prescribing or providing. We are specifically dispensing, and that is technically important. Which of the following effectively describes the effects of hydrocodone rescheduling on opioid prescribing and mortality? Opioid prescriptions decreased and deaths decreased. Prescriptions increased and deaths decreased. Prescriptions decreased and deaths increased. Prescriptions decreased and deaths decreased. And now that you've seen this question, you know what kind of professor I am, and you can imagine how poor my teaching evaluations are. The answer here is prescriptions decreased, but deaths increased. And then finally, what is not a reason that pharmacies do not stock, another awful question, double negative, that pharmacies do not stock medication for opioid use disorder? Fear of enforcement, stigma, prioritizing other medications over buprenorphine, or drug shortages? The answer is drug shortages. There is no shortage of buprenorphine. There is a shortage of manufacturers who are willing to sell it to community pharmacies. My contact information is here. I know that this is a CE talk, but if you're interested in free CE on opioid-related content, please feel free to visit txoti.org. We have 32 hours of controlled substance-related CE in our library. And please feel free to check us out at www.farmprogram.org. I'm sorry I didn't get the claim code for this presentation, but I'm sure it will be sent to you as soon as possible. And if we have time for questions, I'm happy to stick around to take any.
I think we do have a couple minutes. Thank you. That presentation was great, and I love your humor.
Thank you.
Your side job might be stand up. So, anybody, you're welcome to come off mic or to put a question in. I can tell you, I saw some great discussion about barriers. You can go back and look at that. But I did see one of the questions is where can I find that pretty pink flyer? So you want to answer that?
I believe it's in the toolkit or on the Bridge to Care website. If not, can I send it to you all to maybe send to participants? And if
Sure.
anybody would like to get in contact with me, I can send it to them directly. Just Google my name, you'll find my faculty email address pretty readily.
Does anybody want to come off mic or to put a question in? I did see there was one other in here. There was another question in here when you were presenting about your design. Someone had asked how many panel members, experts. This was in the first part of the development of the Farm OUD.
How many panels? How many?
How many panel members slash experts?
So it was
So
a 22 member panel, a 22 member panel. And, we, I think originally set out to recruit 40. Um, I will say that in a Delphi design, anywhere between 7 and probably 40 at the max can generally be appropriate. Large panels, it's really difficult to gain consensus. And this allowed us to have a lot of discussion and also really carefully consider everybody's recommendations when forming recommendations. Our priority was making sure that those 22 panelists were very diverse in who they represented. So we didn't just want a bunch of, psychiatric pharmacists or a bunch of psychiatrists. We wanted people from every background and we wanted those backgrounds to be fairly balanced to make sure that people were heard.
that's great. Thank you. I did also note that there were several people in there that had heard of that town, by the way. So
Really? Oh, wow.
you might
Okay.
owe at
Nice.
least a couple dollars
Stephen at
out
Boston
there.
University is there. I see
Yeah,
that in the chat now. That's
you might
great.
have
That's
owed a couple of
fantastic.
dollars
Yeah.
out there.
Awesome.
I had one quick question before we go, which is with the issue with the wholesalers, the distributors, and the quotas, the limiting access. Do you have workarounds? Do you have suggestions when a pharmacy does come up against something like that where they want to order more and their order doesn't come in?
Yeah, that's a great question. One of the things that we have found that can work is writing a very detailed letter explaining very cogently why your threshold is increasing. Your distributor does not hate you. I think it's important to remember that. You are a customer. They value your business and your relationship. But if you can put it very cogently into writing why you are now dispensing more buprenorphine, that helps a lot. So recently, I've spoken to several pharmacists in Pennsylvania, right, who are dealing with sort of the closure of Rite Aid. And when Rite Aid went away, all of the buprenorphine patients from those Rite Aids now ended up in their pharmacy. Well, that doesn't mean that that pharmacy is now diverting buprenorphine. It just means that they've had an increase in the total number of patients and that their total dispensing trends haven't reflected that yet. And so just putting that very cogently into writing and communicating with your distributor's representative can work. Other than that, we haven't found a lot. And I do think there's still a need for a central solution to sort of make this unnecessary problem go away.
Great. Thank you. That's very helpful because I know I get that question a lot too. What should I do about it? So,
And I will say, if there are pharmacists here, we've helped write several of those letters. Please feel free to email me. Happy to do that.
so you can be a reference for problems.
Yeah, like we're like a help desk.
Yes.
So no funding to do that, but we're always happy to help.
You're always willing
So,
to help.
yeah,
And you can certainly reach out to Max and myself as well.
there you go.
I may not be as great a resource, but I will do my best to
You're
ask.
probably
So,
better. So,
so all right. Well, I don't want to keep everybody. I know it is now a little bit after 1 o'clock. Thank you so much for such a wonderful presentation.